Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. Welcome back to the Dusty Muffins. In today's podcast episode, we are going to talk about midlife lab tests, what you need to know. I'm Dr. Christine Hart-Kress. I'm a board-certified women's health nurse practitioner and menopause certified practitioner, and I'm coming from Northern Virginia. And I'm on today with my lovely two co-hosts, which we'll go ahead and let the one closest to my state introduce herself first.
Hello. I almost asked who that was. I'm Dr. Rebecca Hurdle. I'm a board-certified osteopathic family medicine physician and a certified menopause practitioner in Erie, Pennsylvania.
Brain fog. We should have like a little sound that goes off when one of us, because, you know, in each episode so far, I think, maybe apart from the last one, we've had a moment where we could have had a little, you know, foghorn. Yeah, signaling that was brain fog.
We should use a foghorn. Oh my gosh, when like the word escapes. Mm-hmm.
Exactly, and it would fill the time as well, the empty space. I'm Aoife O'Sullivan. I am a board certified family physician and a Menopause Society certified practitioner who keeps that written on a pad beside the computer because I can never remember. I'm over here in Portland, Oregon, and go by Portland Menopause Doc. And I'm very excited about talking about labs today.
Yes, welcome back. It's so great to all be back together again.
Yeah, Dusty Muffin podcast. All right.
This is a hot topic.
Mm-hmm.
Yes.
It's a really hot topic. Yeah.
It is. And I think patients and clinicians as well are really confused about what's the right thing to do and what's too little, what's too much, what's just enough. So I think we're going to sort all of that out today, aren't we? We're going to fix all the world's problems.
Yes.
With regards to menopause labs.
Mm-hmm. One hormone at a time.
Yeah.
I mean, so all over social media, all over social media, you're going to hear two different things, right? Mm-hmm. You're going to hear a perspective of all the labs all the time because we're balancing your hormones. Balancing your hormones is not, it's more of a functional medicine, integrative medicine kind of concept. Most of us that were trained, even by expert menopause practitioners, don't really subscribe to the balance thing. You will have providers that may say you have to do Dutch testing and spend $500 or $600 to do these really elaborate tests. Some are saliva, some are from dried urine, and gives you the precursors to your hormones and DHEA. And then you'll hear over on social media, you don't need any lab testing, and if anybody offers you a lab test that you should run. And I think the truth therein lies somewhere all in the middle.
Yeah. I agree. I think, will we just kind of run through labs and say how we kind of start and why we think we would order each of those? Like, I'll start. So first of all, when a woman comes into me and she's got her little tracker with her and we're looking at her symptoms and it seems like this could well be perimenopause, but also my brain is also thinking, well, it could be 8 or 10 other things too. And I don't want to miss anything. Now, you know, you can start a woman on treatment while you're checking her out for other things too. So it's not going to be a barrier to care, but we also don't want to miss anything important or anything dangerous. So one of the things I am going to check on her is a CMP, a complete metabolic panel. And that is going to show me that her kidneys are working properly, her liver is working properly. And then we get a little look at things like calcium, phosphorus, potassium as well. So that's one of the things I would start. Who's next?
Yeah, I would probably start, especially perimenopause, with their cycles, which can be really wonky or really heavy, checking like a CBC and iron, or just maybe an iron panel. So because, you know, iron is something that is easily overlooked. If you're still having cycles and they're heavy, it can be very low, or you're not a great eater, or if you don't eat a lot of meat, you could be low in your iron. And I think we underestimate all of the symptoms that iron deficiency with women, from your hair to your mood, to your skin, to, you know, swelling of the legs, even, that it can happen with. So that's definitely going to be on my radar, on my list.
In Ireland, something that's really common because it is a genetic issue and Ireland's a small island is hemochromatosis. So lots of us have hemochromatosis, and because we're bleeding, that's where you have an iron storage issue or iron absorption issue, and you're absorbing too much iron from everything you eat and drink, and it's getting deposited in your organs. But because women bleed every month, it doesn't tend to be an issue for them. Men get diagnosed pretty early. But then when your periods get really irregular and you're not having a period, you know, for months and months on end, that's when women start to get symptoms of hemochromatosis as well. So you're also checking to make sure that iron isn't too high at this time of life. Yeah. So multiple reasons to check your iron panel and your ferritin. Yeah. How about, Christine, your favorite?
Which
thyroid.
Yes, I love the thyroid.
Or D.
Look at that smile. She loves it.
I do love the thyroid. You know,
it's a sneaky little thing.
It is a sneaky little thing, but I think thyroid is important, especially some of the symptoms of menopause, like weight gain, you know, for example, that women have can, you know, be related to the thyroid. Also things like constipation and hair loss and brittle nails. You know, cold intolerance. So, you know, or being, you know, or heat intolerance. And so I definitely think the thyroid, because, you know, we're more than just our hormones, right? So, even though thyroid is a hormone, but I think it's more than just the
ovaries. Yeah.
More than just the ovaries. I think it's really important. Yep. And then cholesterol.
Yeah, very important, because as we lose our estrogen, that's integral for helping control cholesterol production in the liver. And as we lose our estrogen, our liver ramps up production of cholesterol and it tends to go wacky. So you want to know what that is.
Yes.
So a lipid panel.
Yep. And I'm going to touch just on the thyroid again, too, is to make sure hyperthyroid, because I think all the women come in and say hypo, but boy, when you're feeling really anxious and you're having palpitations and you can't sleep at night, sometimes that thyroid is hyperthyroid and it's overactive as well. And that's really important. I think even more so, that really needs an endocrinologist to help manage that hyperthyroid. So
yeah,
for sure.
And I think we were all trained to just go by a TSH, right? A thyroid stimulating hormone. But I think we know better now, and that there are more thyroid labs that help give us more information. Like in a cholesterol panel, we don't just check a total cholesterol. We check the LDL, the HDL, triglycerides. And so we would also check some other thyroid tests like the free T4, free T3, and thyroid antibodies. Right?
Hashimoto's, that, you know, when you have antibodies, Hashimoto's, that autoimmune aspect where your thyroid is under functioning, but it's from an autoimmune response. And autoimmune disorders show up in perimenopause and menopause for a lot of women.
Right. Yep. And I would suffice to say, I mean, I think the last statistic, and that overall was 30% of all women have some type of thyroid dysfunction. I would be safe to say it's more than that even. But that was my last board review family medicine board
Oh,
review.
That's really interesting. Yeah.
Yeah.
And then hemoglobin A1C,
Very
so
important.
many women become insulin
100%.
resistant with that
That's
decline in estrogen. And, so much prediabetes we see show up
That's
in
right. You're fasting
that transition.
Yeah. And, Dr. Vonda Wright, who's an orthopedic surgeon and very much cares about menopause as well, will say, fat is an active organ. It doesn't just sit there doing nothing. It's doing detrimental things. It's having an effect on our metabolism. And that's where things like our cholesterol and our sugar are affected as well. When we start to gain that weight around our middle and it starts being deposited down in our liver, and around our kidneys and everywhere else. How about what I often find in my patients, and I don't know if this is a change in our microbiome perhaps, but is that I see a lot of low B12.
Yes.
Yeah, vitamin B12 for some reason drops around our age. And can give you symptoms of things like brain fog and word finding difficulties. Like it affects your brain. And even though on the LabCorp or Quest form, it will actually say, I think from 200 and something upwards is normal. Then underneath in fine print, it says, but this big percentage of women actually have symptoms below 400.
100%. I would say our local neurologist will says all the time anything under 400 needs to be replaced.
Yes.
Doesn't mean that you need the injections. I do find that my patients will do both, and it's just so easy for them to go get a tablet and take it at night. And but even young female athletes and their B12 as well. And the other weird thing is those paresthesias too, right? With that B12, right? The numbness and tingling pins and needles.
What I'm finding is two spectrums on the B12, ones who are low and, because they fell within the normal ranges on the lab. Remind me to mention something about that. And then yesterday, I got 4 labs back and B12 levels were over 1600 because women think B12, like I should take B12. It'll help me think. It will help me with my mood. I don't take B12 until you have your B12 checked. I have, I was speaking to one patient and she was taking like 2000 milligrams of B12 every day. And her levels were 1800. I'm like, stop the B12. You're not low. You're way too high now. And
I also tell them to hold those supplements for 2 days before they get their lab work done too, because it could falsely elevate them. I mean, I don't think I ever knew that. It was somebody I worked with that was checking something and was teaching me that. And I'm like, oh, I think I always forget to tell patients to do that. This was, years ago.
And anything with biotin in it, you have to stop for 2 weeks.
Yeah.
2 to 3 weeks to get it out of your system.
Yeah. I think we forget, and women forget that you guys, some supplements are still medications,
Yeah.
So.
Vitamin D.
Yes.
And that brought me back to, I'm going to go back and then I'll go forward. So those lab levels, the lab levels on your lab reports are just the average of the people who go to that lab, the lowest and the highest. They're not necessarily normal levels and not necessarily normal levels for you that you'll feel good in, which is why so many women get their hormones done and are told your lab levels are normal and darn well you don't feel good. So that's one thing I would say about those lab levels in general on the lab sheet. So vitamin D, when you have low vitamin D, I find in midlife, if women's vitamin D levels are below 50, they tend to have more fatigue, more mood changes, more sleep issues, more hair loss, more muscle weakness. So I really like lab levels on vitamin D to be at least 50. And if you live somewhere, where you don't see a lot of sunshine and you can't get outside for 20 to 30 minutes and let light hit your face, you're probably going to be, low So,
and no sunscreen. That's sunlight, no sunscreen. If you wear sunscreen, you're not going to get your D. We forget that, I think, too, right? Like, I go out, I'm outside all the time. Well, if you're applying sunscreen, you're not getting your D.
Yeah. So do you think that brings us then to hormones?
You know what I want to talk about, only because I'm having I saw on another influencer who talked about magnesium, and I can't remember who I was talking to yesterday, and we were I from another influencer, I started checking magnesium levels on everyone. They're all always normal, but yet magnesium, they say most people are deficient in magnesium and benefit, especially from the sleep perspective of taking magnesium at night. And someone that I was talking to, someone really smart, told me why serum levels of magnesium are not accurate.
Because it's intracellular. A lot of it is intracellular. Yeah. And so you can see what's in the bloodstream, but you can't measure what's in your cells. And it's whether or not it's in your cells that makes a difference. Yeah.
And those, usually my older patients are the ones they're usually like the leg cramps and things like that, or leg pain. And before the heart starts.
Yeah. So I don't check magnesium levels unless I have a cause to. Yeah.
I don't anymore.
I just tell them all this. Yep, I don't either.
But that's good that you brought it up, Christine, right? Because we see these patients coming, having had hundreds of thousands of dollars of testing done. It's not necessary. You know, there are times when we will check a magnesium, but not just because you're coming to us with perimenopause symptoms.
That's right. Okay. And a couple outliers out there, especially where I live anyway, when you're coming in with some like achy joints and joint pain, I may talk to you about a Lyme. So, you know, or mono with the fatigue, because, you know, like right now we have an uptick of mono that I'm seeing in our community anyway. So, but Lyme disease, right? Those are just things that, like, you know, if your PCP isn't already on top of it, it's just some things that, and I've seen Lyme without a history of a tick bite. It was probably a couple of years ago, it was rampant. And I probably saw 3 or 4 without a history of having a tick bite. And so, yeah.
Yeah. When you go to see one of us or any clinician, you know, we've all been taught to keep a running differential diagnosis in our heads. So that is a list of probably 7, 8, 9, 10 things that could be going on. And we're going to be working up the first 2 or 3 of them. But, you know, so that's where things like, it's always great to be thinking outside the box as well about things like Lyme. And so you wouldn't necessarily always, for every woman that comes in, check anything for Lyme, but it's on your list. It's on you're thinking about it in case things, you know, a few weeks from now are not going as planned. And then you're kind of back to your list to see what else could this be.
I think that's if you're seeing someone that has a primary care or family practice. I am not thinking Lyme's disease. I'm thinking you go back and find that primary care provider.
Get out of here, lady.
Yeah.
Yeah.
It doesn't have anything to do with anything I work on.
No, I'll tell you what, it's amazing when they come in with just some like, you know, joint inflammation, and you're like, but sometimes it's not. Right. Sometimes it is just their menopausal symptoms, and you know,
often for the group that we see, definitely. So does that bring us on to hormones then?
I do.
Yeah,
I do.
Okay.
And I think the important thing to know, which I think is absolutely the truth, right, is that we don't need them to treat or diagnose. We don't need hormonal levels to treat or diagnose, or to decide what we're prescribing. I think that part I would agree with, that they are not necessary, but
I agree.
Right. Especially in menopause, right?
Yeah.
I think we talk a lot about that. Like, it's validating. It can be validating, but you just have that explanation. Like, it depends on what your ovaries are doing that day.
Yeah. And, you know, let's talk about premature ovarian insufficiency, which is a woman who's noticing perimenopausal symptoms before the age of 40. And early menopause is when you stop having periods before the age of 45. So we always do lab work in those situations to see what your ovaries are doing. We need to know that, because if your ovaries are not functioning as they should, then we need to replace your hormones. That's standard of care.
Mm-hmm. Yes. Yeah. And replacement, not just menopausal
Yes.
hormone at a lower level. This is replacing. It's a whole
replacement.
Different.
Right.
Yeah.
And I would say that those women are the only women that I do an FSH and an LH on, because in perimenopause, it's going to be up 1 hour, down the next. And by the time you haven't had a period for 366 days, it's going to be elevated if you are at the natural age of menopause. So from a, to me, I find it not to be necessary.
Yeah. You know how sometimes you meet women who say, I had a period last January and I never had a period again. And then other women will say, I had a period in January, one in March, one in July. Mm-hmm. And so sometimes I do have someone come in and say, I haven't had a period. My last period was 4 months ago. The one before that was 3 months ago. And sometimes I will check an FSH then and tell her to come back 6 weeks later to do it again. Because sometimes you'll be able to say to her, you don't need to worry about birth control or anything anymore, because your FSH is sky high. We've checked it twice just to make sure, and you are menopausal, So then they don't have to wait for the whole 12 months.
Yeah.
That's true.
So
the other one that I check that's a little controversial, and I think it's how I was trained. I was trained by a really great OBGYN who we did AMHs, anti-Mullerian hormone levels. What I was trained was, if your AMH is less than 0.04, 76% of women will stop their period within 1 year, and that you have zero chance of pregnancy. I like watching AMH levels fall for women in perimenopause. And, I find after years and years of testing them that they usually fall by 50% every year. But I will say, although I do check them, they're a good predictor of menopause, but not a good predictor of when it will happen. So if you're menopausal and they're low, well, then it's a good predictor. But I find it to be just part of the information. And I think it's helpful for women. I find it helpful for my patient to have that, but I also understand how to explain it to them.
That's one I have not used really, unless it's in early menopause or premature ovarian insufficiency. Yeah.
Yeah, me either. I will do an FSH for them because they usually want to know. And I think sometimes, when it is perimenopause and it's like, 5, 7, I just tell them, yep, just like we thought, you're perimenopausal. Once that gets over 30 consistently.
Yeah. I saw someone shared with me on social media their lab panels, what they were having drawn every 3 months. And they were having an FSH, an LH, a DHEA, a pregnenolone, and a progesterone every 3 months. Well, the FSH was 85. It's not going to be it's not going to be below 30 ever again. And I was like, and they were paying out of pocket for it. They weren't even sending women to their lab. And I was like, you don't need that. Like this whole thing about
any of it.
Progesterone. So, that's the one level that we don't check regularly, because it never is, unless you're, unless you're pregnant, or unless you're, like I've seen it when we've used it with infertility patients, and their reproductive age, a progesterone over 10. But even on women who are on 400 or 600 milligrams, which I don't see too often, a progesterone, their level is never high. And Rebecca and I met with a pharmacist who explained, although it is eliminated from the body through the liver, it's excreted in urine and bile. So it's not going to be in your blood serum. It goes through, it's lymphatic. So if you got a urine, or if you finger pricked your blood, then you would see, a progesterone level that's more than 10. But in the serum, that's not where you see it. So similar to that magnesium piece of where it goes. And so, pregnenolone is the precursor to progesterone. And I see women getting them tested all the time. I don't need that. Like, I don't check progesterone at all. If you're doing great, we keep you on the dose. If you're not sleeping, I give you more.
Yeah. It's not, that part isn't rocket science, right? And these poor women are, it's a lot of money that you don't need, and and they're just, it's another thing for them to just, really obsess about or be upset about. And, I don't want that. I want to titrate and tweak your medicine, make you feel fantastic as much as we can, and then let you not worry about those things unless we need to worry about them.
Yeah. So we're giving you the progesterone for one reason, to protect the lining of the uterus so that it doesn't get thicker and thicker and put you at risk of increased risk of endometrial cancer, which is a possibility for all women. But if you're taking your progesterone, then you don't increase that risk when you're on hormones. But also, one of the reasons we use it is for anxiety and sleep. And the way it helps with that is by being converted to a different metabolite called allopregnanolone, which we don't measure. So checking the progesterone doesn't really help us at all. Yeah. I think we're all in agreement with that.
Well, what about all I see women come in with their estradiol, estriol, and estrone tests.
And estrone. I see that one too.
I know. I mean, the thing is, you can't tell what's going to happen once somebody takes estrogen, right? Some of it gets converted, especially if you take it orally. A lot of it gets converted into estrone. So I never check those. I can't see how they could be useful, because you can't do much with that information. I was always taught you do a test if the result is going to change your management.
Right. And estriol and estrone do not.
No.
Exactly. No. And quite frankly, I only check an estradiol if something's going wonky, if I need to. If I don't think you're absorbing something, I'm really just trying to prove that to ourselves. Or, if you're bleeding, and even then if you're bleeding, I might just back off first instead of, checking levels. So I think you have to have those conversations are so important to have every time you meet with your patients about why you're doing it, what's the meaning behind it. And then if you decide to come together and be like, okay, you know what, maybe let's check this. If that, and this is why we're going to do it.
Yeah, I do regularly check my new patients. I will check an estradiol for them because, a new patient. I will check estradiol in all my new patients. And then at their first 3-month visit, I do check it again. And then it really just kind of I'm really just to give the patient information. I think it's helpful for the woman who is, who wants to see if the medicine actually does increase her levels. I think there's some women who just want that data. And I think, for absorption, but I also think for women that are when we talk about trying to decide if we're going to go up on a dose, are the symptoms improved, right? How improved are they? And I think that there's, for some women, they're well, I'm not suffering as much as I was before, so I guess it's okay. And so when we look at levels and, maybe the estradiol went from less than 5 to 20, and they're I'm not as bad as I was, but anything 20 and less is in the menopausal level. Then having that information, I have found, has helped guided some conversations for women that they are then oh, yeah, I want more. I they feel they're greedy for, because we don't know what is going to work. We just try something and we always go low and slow. And so I find that, ordering them, and then, then when I see they're absorbing and they're all good, then I don't, usually check them unless there's a problem.
Yeah.
How about you, Ava?
I vacillate between saying, no, I'm not checking them, to, yeah, I like checking them. initially, just to have a baseline, because I find that sometimes down the road, someone is not responding to treatment like I would have thought they would be. And I love having something to compare this new value to if I check blood work. So, so I'm always kind of, I have like one, you know, I'm on the fence about it, but I think if I was to pick one, I might check an estradiol level with the first set of labs. Yeah. But it's also important when you do that, right? Like if you have a perimenopausal woman, you don't want to be checking her estradiol levels on day 14. So you really want to check it in the first few days of her period, somewhere in the first 3 days, if possible. But 3 to 5 definitely, because that's when your estradiol levels are going to be the lowest. And that's what we want to see. What are they really? What are you dropping down to? So timing is important if you're still having periods. And that's so easy to say and much harder to do, because Quest and LabCorp want you to make appointments. And when you go to make an appointment, it's booked up for 2 weeks and you don't know when your period is coming. So even though we say all this, we do realize that there are barriers to that as well. Like,
And really in perimenopause, those estradiol levels are really only best for trending. You know, so that you can just see what you're doing over the course of time.
We've seen some doozies on those.
And we want to make sure
700.
If you're coming back and you're saying
you feel terrible,
but if you say you're not responding to treatment and we check your levels and it's like 500, then we're probably going to start looking at your ovaries. Like get a scan, make sure you don't have an ovarian tumor or something that's producing lots of estrogen. Because there are things that don't make sense.
Right. We're not always looking for low levels. Sometimes we're looking for your highs as well.
Or if you're stuck in a loop cycle, those estradiol levels can go really high.
Just say what a loop cycle is, Rebecca.
Yeah. So a loop cycle is where the brain is telling your ovaries, I need some estrogen, I need some estrogen. And your ovaries are like, I don't really have any. I don't really want to give you any because I don't really have it. And then eventually the brain is like, listen, give me some estrogen now. And then it kicks this off, but it's this high level of estrogen. And so these can be, 300, 400, I've seen 700. And I did look for other things too, because it scared me. But these women are miserable. Their boobs hurt. Their mood is terrible. They're bloated. They are just, they're rageful. And then you'll recheck it. And they're like, oh, I feel bad. And then it's back down to like 5, or whatnot. So so that the brain really kind of like the thyroid, right? When there's a low thyroid, you have hormones that are like, send me signals because I need something. The same thing with the brain and the estradiol. And so you get more of those. The later in perimenopause you go, you can get stuck in these cycles where the brain is just like, I need this to function because there's estrogen receptors in their brain. Right. And your ovaries are like, I really don't have anything to give you.
Well, and then on top of that, when they're doing that, they're bleeding every time right afterwards, because the ovary will release an egg, but it usually isn't a very
good one,
a very robust egg. And so you just bleed. And so that's when we see those loop cycles and you start bleeding all over the place.
Yeah. And I agree. I'm in between the middle before we wrap up and do our key takeaways.
Well, we still got testosterone to talk about.
Oh, we have testosterone. Oh, yeah. I was going to say I'm in between, I would say, Aoife and Christine. So I usually check it in the beginning and I am plus or minus if I recheck again, depending on what's going on. Some of my women like to know for their own data, and I'm just, I don't mind it. But again, letting them know that if you feel good and you're, that 75, 80, 85% better, I'm not looking at a level to get you to, because we just don't have the data that we have. We have a range that we think is the best, but we don't have a number.
Yeah. How about testosterone?
I love it
so much.
We test it. Total testosterone is what I most likely am to order, as a total testosterone, looking for levels less than 55.
Yeah.
Most of them are less than 10.
Oh God. Yeah. I rarely see one over 17. Yeah. When I check.
And with that, a sex hormone binding globulin, just because if you have a level more than 170, if we give you testosterone, you're just going to bind it and you're not going to be able to use it. And so like women who are switching from like oral estrogen, they have very high sex hormone binding globulins. And so giving them testosterone, either we have to give a lot more or it just takes a lot longer to work. So I like to check that sex hormone binding globulin to see. What are your thoughts on, I've seen a lot of people getting their DHEA and DHT levels. You know, the DHEA, you know, is produced in the adrenal gland and helps the body make testosterone. And then testosterone is is converted to DHT or dihydrotestosterone. And I see people ordering the pre and the post cursors. I mean, what do you guys think of that?
I don't ever check DHEA.
Yeah, me neither. DHEA is when I'm looking at a patient with polycystic ovarian syndrome or something like that, but not for perimenopause.
Correct.
I don't.
When you're looking for adrenal tumors. Yeah.
Yeah, exactly. Yeah. So that's a no from me.
No for me.
Yeah.
Yeah, I mean,
negative Ghost Rider.
I mean, there's so many things, right? And like, I think.
And what are you going to do with it, right?
Is it going to change my management? No, it is not. So do I want you to have to pay for that if your insurance company refuses to pay for it? No, I do not. No. Could I stand in court and say it was a necessary test? No, I could not.
Absolutely.
Right. And again, if you need the estradiol and the testosterone and the progesterone, that's what I'm going to give you. I have no idea what your body's going to do with that DHEA if you take it orally, if you put it on your skin. I don't know how much of that's going to be estrogen, how much of that's going to be testosterone. And so that's,
And I think in the studies that
we, go ahead.
Sorry, Christine, that we do have, you have to use very high doses.
Not good for your liver.
And some people will say they've started taking it themselves and they feel better. No problem. I don't think there's any real danger in taking a dose that's over the counter. But as for me prescribing it, no. Because I wouldn't know what I was doing. Yeah.
Right.
Vaginal. Yes.
You know, the one thing I was going to say about testosterone and testing for your labs, that if you normally dose your testosterone in the morning, hold it before you get your lab, because that testosterone is going to peak in 4 to 6 hours. It's the lowest point at 14 hours. So if you take it at night, it's usually fine. But whenever I see a really high testosterone, like above 100, I always ask the patient, when did you put on your testosterone? So you do need to hold that if you're a morning testosterone doser before you get
And did you put it on your forearms exactly where you had your blood drawn from?
Yes. That's a good one.
Yeah, that's a really good one.
That's not where I told you to do it.
I know.
I know. You like the deltoid.
You want to know why? Because I forget. And then I'm like,
show us your hairy shoulders there, Rebecca.
She's like,
I want to see those hairy
like,
shoulders.
The babies with the No,
I got the biceps. Maybe that's why my delts.
You like those hairy little babies now.
I'll tell you what, though, it does make like your inner thigh hairs coarse. I have nothing, no changes,
on
none,
the deltoid?
0. And I almost consistently put it on the wrong side because I always forget to alternate. I do try. I really do.
And where to put things like gels and creams and stuff comes from wherever they did it in the study they did, right? It's not this hard and fast rule that's written in blood somewhere that you can't change where you're. Right. But if you put it in the same place every day on your thigh, you're going to get a big patch of hair there, or your calf or whatever, you know?
It's so weird. You don't, don't be doing that. Your delt,
I know. There's nothing worse than being at the beach and looking down between your legs and going, oh.
I forget that patch.
Right. You know, I've been telling everybody about the deltoid, like you said, and then I said, or you can do it in your calf. I said, because one of two things are going to happen. You're eventually going to shave, or you don't, and so who cares?
Yeah,
that's right. Exactly. Yeah, and I think here, like I said, what's nice is when I was telling another patient about it, she's like, I do it too because I forget. I'm like, I know. And so you just go pull out your shirt and slap it on.
I'm gonna do that tonight. Let me see what happens.
Try it, and it's nice because it's in a spot I know is going to be covered. So, you know, I'm not worried about my, my husband trying to rub on my shoulder, trying to get some of my testosterone.
That's never where he's trying to rub on to. Don't worry.
Yeah, you're right. That's 76.
Oh my gosh.
Jamie.
All right,
I'm
Aoife,
like,
take
86.
us to takeaways before we, totally go off the rails.
Okay. For our takeaways, I'm going to list the lab work that we think is very reasonable to ask your clinician for, and very standard and helpful, and would change your management if something came back abnormal. So the first one is a CBC, or a complete blood count. Second is a CMP, a complete metabolic panel. Then you've got your iron panel with ferritin. Then you have your thyroid panel, which is a TSH, a free T4, a free T3, and antibody levels. You've got your lipid panel, and there was something I meant to go back to and I forgot, but I think nowadays everyone should also be having 2 extra lipid tests. One is called a lipoprotein little a, and the other one's called an ApoB, and you really only need to have them done one time, but it shows genetically how likely you are to have problems with cholesterol. And whether or not you need your normal cholesterol treated or not. It gives you more information to make decisions. The next one is your hemoglobin A1C, which is your test for what your sugars and glucose levels are doing. Vitamin B12 and vitamin D. If you have premature ovarian insufficiency or early menopause, or you think you do, then an FSH, a follicle stimulating hormone, can be really helpful. And then the other hormones that we check are estradiol, or can check estradiol, testosterone, and sex hormone binding globulin, which is a protein and can affect how much active testosterone you have in your body. So all of those are normal blood tests. They should all be covered by your insurance if your clinician's able to code them so that they're covered. And would definitely change your clinician's management of your issues should any of them come back abnormal. As for all the other things we mentioned, we wouldn't know how to make sense of them if we tested them for you, what to do with them when they came back, and how to help you if they were abnormal. All right, our midlife tribe, remember you're not alone in this journey. Be informed, be empowered, and keep thriving through midlife. Until next time, stay fabulous.